Good evening. It's my pleasure to welcome all of you to our seminar this evening, which is a patient-facing seminar brought to you from Weill Cornell Medicine. We are physicians that are part of Weill Cornell Medicine and also New York Presbyterian Hospital. And it is my pleasure this evening for us to talk about an extraordinarily common condition known as GERD, which stands for gastroesophageal reflux disease. And we're going to speak about how do you diagnose gastroesophageal reflux disease, what can we do from diet and lifestyle, and also our understanding of the role of medication. My name is Dr. Felicia Sussman. I'm a gastroenterologist in the Division of Gastroenterology at Weill Cornell Medicine, and I'm joined this evening by three of my colleagues who are experts in the field of gastroesophageal reflux disease. The first is Dr. Carolyn Newberry, and she's an expert not in just gastroenterology, but also in nutrition and our understanding of the interaction between nutrition and disease. I'm also joined by Dr. Philip Katz, a internationally recognized gastroenterologist and esophagologist who is the former president of the American College of Gastroenterology and can lend an enormous amount of knowledge also to gastroesophageal reflux disease, as well as Alexandra Rosenstock, who is a registered dietitian, and she works incredibly closely with so many patients in how to manage gastroesophageal reflux disease with regard to diet and lifestyle. Now, on to our program. So, gastroesophageal reflux disease is an incredibly common condition, and I'm sure many of those on the webinar this evening, either they suffer it or they have family or friends who suffer from gastroesophageal reflux disease. And it's almost impossible to not actually hear about either someone who has it or medications that those of us might actually be taking. So, how common is this condition? This is a nice quote from Tolkien, and I'll allow you to read it. So I'd love Dr. Newberry to actually spend a little bit of time with us talking about just the broad strokes of this condition.
Sure. Thank you so much, Dr. Schnall. I'm very excited to be here, and I'm excited to dive right into this very common condition. And I can see there's a lot of interest here on the webinar to talk about this. Gastroesophageal reflux disease is one of the most common gastrointestinal diseases in the United States, and one of the most common reasons that people make an appointment with a gastroenterologist. We actually believe about 1 in 5 people, or 20% of people in North America, have frequent reflux disease. And when we say reflux, we mean heartburn, burning chest pain, sour taste in the mouth. We're going to get a little more into the details of that, but just to clarify what we're talking about here. We also find that a large number of people in the United States have frequent symptoms. So there are some statistics that show up to 1 in 3 people in the US actually have as much as weekly symptoms. And there are a number of risk factors that we think about with this disease, one of them being male gender, another one being advancing age, excess body weight, particularly central excess body weight, people who smoke, and people who drink alcohol, all are people that are increased risk of developing reflux symptoms.
So, Dr. Newberry, when you think about these patients and you see these risk factors, are there women who also, I mean, obviously, this is a common thing, but I'm sure you also see many women that also have this disease as well. Is that correct?
No, absolutely. I mean, just looking at the statistics, if 1 in 3 people are having really common complaints, we have a lot of female patients and male patients. And actually, some of the risk factors for reflux include things like pregnancy, which obviously are affecting only women. And so there are lots of ways that we treat women in the office as well.
Yeah. So, I mean, basically what we're saying is this is such a common condition, which is why we, want to talk about this. And it really can affect people's lives. It can affect how they sleep. It can affect their work environment. It could affect them going to school. It could affect potentially every meal that they actually are trying to enjoy. So it's something that just really most gastroenterologists see almost daily in their practice if they're a general gastroenterologist.
So Dr. Schnell's symptoms don't actually discriminate by age.
Hmm.
What discriminates by age are complications and severity. So
Hmm.
as people reach um, maybe my age, the disease is more severe if it's untreated. If you happen to be one of you, it is likely to be less severe, but your symptoms are going to be as frequent.
Hmm. Yeah, I mean, I think that's interesting that that you say that. I have children that are in college, and obviously, maybe a lot of people on this call have, let's say, teenagers or individuals in their 20s and 30s, and they might experience a lot of symptoms at that point in time. But I guess what you're saying, Philip, is that it's potential that even as people get older, that the side effects from this disease could actually worsen.
That is correct.
Hmm. Okay, so it's really important to understand, what is this disease? And we're going to definitely go into that. But in order to sort of illustrate that, I'm going to first start with discussing a case. So this is a 48-year-old woman, and she's been feeling like her throat is on fire. And she's been experiencing this symptom on and off for about 4 months. She weighs 165 pounds, and her height is five and a half, 5'5", and that gives her a BMI of 27.5, so not bad. She takes over-the-counter antacids for her symptoms, but they really only partially help, her symptoms. She eats her dinner at around 8 o'clock at night, and then she goes to bed shortly after at around 9 o'clock. And she maintains a balanced diet. She basically watches what she eats, fruits, vegetables, but she also has frequent carbonated beverages and coffee as part of her diet. So, what exactly, and we'll go back to this case, but we're just setting the scene for potentially a common type of patient that all of us, may see on a daily basis. So, what exactly are gastroesophageal reflux disease symptoms? So, Dr. Newbury, what is this disease? What do people experience?
Sure. Yeah, thank you. So there's a number of symptoms that people identify as being part of reflux disease. Two of the most common symptoms that patients come to us with are heartburn. So that's really feeling like throat is on fire. You feel burning in this chest region, and regurgitation. And what regurgitation is actually where food and fluid comes up into the throat. You may feel a sour or bitter taste in your mouth. Some people even actually regurgitate food, undigested food, back up into the throat. And obviously, that can be very uncomfortable. In terms of other symptoms that people sometimes experience as part of reflux, acidic stomach contents, there are symptoms that are outside the GI tract. We often call these our extra esophagus symptoms. These include things like having a sore throat, having a cough, um, and many times there's other reasons for those symptoms, but if you are having those symptoms and you have classic medication and making anti-reflux lifestyle modifications, it is important to note that symptoms are definitely not perfect predictors of the presence of reflux. And so it's important if you have these types of symptoms that you're scheduling an appointment with one of your gastroenterologists here on the call to talk about what is exactly going on, because there's a number of tests we can do to really clarify what the diagnosis is.
Hmm. Okay, so when we see these symptoms, do we worry about how long someone has had them, or, is there anything about, because these can be pretty common. I'm sure most people have probably experienced them at some point in their lives. So is there something about how severe they are or how long that they've had them that makes you even more concerned?
No, absolutely. I think most people have identified some heartburn at some point in their life. So if you are somebody that has occasional heartburn symptoms, particularly after a common dietary trigger, you eat a spicy meal, you eat a large meal, you eat late at night, and you have some heartburn, that may not require a doctor's visit. Now, if you're having heartburn on a regular basis, it's happening on a daily basis, you notice that the symptoms are getting worse. You start noticing trouble with swallowing, maybe food's getting stuck in your throat, you're regurgitating some of that undigested food that I mentioned back up into the throat, you're having pain with swallowing, you're noticing having trouble eating, and actually you're having weight loss associated with that. These are all reasons why you should talk to a doctor because you may need more testing.
Okay, so what I'm hearing is that it's very common, obviously. The most common symptom is going to be this heartburn and maybe this regurgitation. And if you have that not frequently or maybe associated with overindulging in, food or whatnot, it could potentially be okay. But if it's really frequent or there are these other alarm symptoms, things that are more seem like they're more worrisome, that's when you should look to go present to a physician for further evaluation.
I agree with
Dr. Schnall, there was a time that we used to say if you had heartburn more than twice a week, you should think about seeing a physician. And the over-the-counter medication is labeled in such a way that if you need to use the 14-day over-the-counter proton pump inhibitor more than a couple of times, you should think about going to see somebody to either your primary care person or a gastroenterologist at that point in time. If that helps expand upon what we've been talking about.
Yeah, no, and I think, some of these symptoms, I think some of the symptoms are probably going to be better understood if we really understand more deeply what's happening inside the person. So, with that in mind, I'm gonna, or I would love us to actually, switch to the anatomy. Why do certain people that have reflux disease get certain symptoms? And Dr. Katz, perhaps you can actually start to, this is a complicated, sort of diagram, but maybe you can start to explain, where is reflux happen? What part of our body is reflux happening in that people get these symptoms?
Can you go to the next slide just for a minute? Okay, so what you see there is an outline of a reflux episode coming up into the esophagus. At the bottom, you've got two lungs on the right side. Dr. Schnoll, you could probably point those out. When the valve at the bottom of the esophagus that links the stomach and the esophagus, where the diaphragm or the breathing muscle is, when that sphincter muscle pops open when it's not supposed to, the acidic contents in the stomach can reflux up north. And if it comes high enough, in the setting of what Dr. Newberry talked about as regurgitation, you'll feel a water brash or a taste in the mouth that will almost be a little bit salty. As it comes up, it may burn, or you may feel full. And that is what the anatomy, if you would, of a reflux episode in that busy body of ours.
hmm Okay, so when we're looking at this complicated, organ, and people have reflux symptoms, could you just describe for us, what exactly does the esophagus do, Dr. Katz? Like, what is the esophagus' role in the body?
So it is a tube that connects the mouth to the stomach.
hmm
It's bordered by two sphincters, which are muscles that
hmm
are under some voluntary control and are somewhat involuntary.
hmm
We chew, we masticate, we get food in the mouth, we swallow, and that opens two sphincters, one at the top, one at the bottom.
Okay.
And then there is a sequential contraction that transports food or liquid from the mouth to the stomach. And that's essentially the primary function of the esophagus. Once the food comes into the stomach, the muscle stays closed, hopefully for as long as need be for the food and the liquid to digest and move from the stomach into the small intestine. If when the stomach distends, the sphincter muscle pops open, you might have a reflux episode.
Okay. Okay. So the reflux, just that we're all clear, when we're talking about reflux, reflux is contents that are coming from the stomach below the esophagus, then now going back up. Well, then that's this regurgitation. They're going back up because this sphincter, as you said, was keeps on popping open. And then those contents are going back up. And it's that movement of that acid and fluid and maybe food that then gives the different symptoms that we're speaking about.
That is absolutely correct.
Okay. Okay.
And a
So,
better description than mine.
well, and this picture, obviously, we're looking here at images from the inside of the chest. And, I think what's interesting to realize is, you spoke about the fact that the lungs on the outside of the chest. Now, what roles, I'm sure there's some people that they realize like the symptoms are very diverse. And Dr. Newberry was talking about the fact that there could be this taste in the mouth, they could have cough, maybe they could get pneumonia. What is the relationship between reflux and these pulmonary symptoms that sometimes people get?
Well, that's a beautiful question, but you can see by looking at this diagram, regardless of what your medical background is that everything is fairly close together,
Mm-hmm.
and they're connected by nerves as well as the potential for direct contact. So a reflux episode, uh, if it comes up high enough and in the appropriate circumstances, could potentially leak or aspirate small amounts of acidic contents into the lung.
Okay.
That could ultimately produce disease. When you reflux, or when you breathe, when you cough, even when you swallow, there are pressure changes so that these organs move in different ways and can connect through what's called the vagus nerve. And that nerve, which basically is responsible for messages throughout the chest, can cause changes in the lung as well as in the esophagus that connect.
Okay.
Patients who, okay, I'll stop
No, no,
there.
no, no, no. So basically, what you're saying is this is a very, very complicated type of interrelationship between these organs, and sometimes the reflux goes up. You feel the symptoms inside the esophagus. Sometimes the reflux can even go into the lungs, and that's potentially why they can get some of these other crazy symptoms that are associated with reflux disease.
Yes, and sometimes the link can go the opposite way. So people who have asthma, for example, can affect the way the pressures in the chest are, and that can actually increase GERD. And people who have sleep apnea, for example,
Hmm.
because of what that does to the pressures in the chest, can sometimes trigger a reflux episode.
Okay. So very complicated, lots of different symptoms that people have. So this gastroesophageal, it's just not one symptom, right? So there are many shapes and varieties of how people can present with just reflux disease.
That is absolutely correct.
Okay. So going back to our case, she's initially recommended for an anti-reflux lifestyle. So, Alexandra, could you just tell us, if you think someone has gastroesophageal reflux disease and we're, sending them to you for consultation, what is an anti-reflux lifestyle? I mean, I know there's a lot of books on these things. Can you
Mhm.
help demystify this for us?
Sure. Thank you for having me. I'm happy to be here. And I always love seeing patients for this prior to starting on any medications because sometimes it really can be controlled with an anti-reflux lifestyle. And it's one of the things I love about being a dietitian. But I always talk about how a person eats, not just what they eat, but how they eat, whether they're eating very quickly and then perhaps eating too much at a meal. Because sometimes when we eat quickly, we're not registering that we're full yet, and that can lead to overeating, um, which can sort of increase the abdominal pressure and create some relaxation in that lower esophageal sphincter muscle that Dr. Katz was talking about.
Hmm.
So slowing down, making sure not to stuff ourselves, kind of eating more small, frequent meals is advisable. Um, Also not eating too close to bedtime. And that is about gravity. You know, if we're eating and then we're laying down, we don't leave enough time for the contents that we've eaten to continue to digest by gravity. And we're more likely to have those episodes of regurgitation if we lie down. So I'm
Okay,
often recommending.
so let me just, this is a really interesting thing that you're talking about. So basically what you're saying, Alexandra, is that just sitting upright, let's say after the meal, that makes a big difference in helping, preventing reflux disease.
Mhm.
Okay.
Yeah.
Okay. Interesting. Okay. So that's, and would you say that's a big component why people have reflux?
I see that a lot. I see that frequently. If they're eating too late, like, I get home at 8 o'clock from work, I eat dinner and I'm exhausted, so I go to bed at 9.
Mhm.
Um, that's common.
Okay. Okay. So, you said smaller meals, how fast they eat, when they go to bed after they eat. What other things are anti-reflux lifestyle types of things?
Well, so in terms of food, there are all these lists that people can access on the internet about foods to avoid, and it's different depending on the mechanism. Some things can relax that muscle, the lower esophageal sphincter, such as peppermint or caffeine. Um, and other foods might just feel more acidic. So depending on what their symptoms are, if they're getting a lot of regurgitation, I would advise, avoiding carbonated beverages and peppermint and caffeine. If they're really complaining more of burning, then I might, discuss more some of the foods that have more acidity, like tomato sauce, spicy foods, raw garlic sometimes can do that. Fried fatty foods. These foods delay gastric emptying, meaning they cause food to stay in the stomach longer, and then that would lead to more reflux when the person actually lies down later.
Okay. So it's not really just one diet, or it really works differently for different people, it seems to me, right?
Yeah.
Um, okay, so let's just see what happens here. And I really want to, better understand, because people love to eat, right? I mean, the reality is, as a doctor, and I'm sure all of you feel this way, I really don't like telling people not to eat their favorite foods. So, I guess part of what, is interesting for me to think about is, when we look at some of these long lists, which is a long list here, and, Dr. Newberry, I'd love for you to comment on this because, the anti-reflux lifestyle, it's a real bummer sometimes, these things. I mean, it really is a lot of the things that a lot of people like to do. And does someone who has reflux, do they have to do all these things? Do they have to cut out all these things, or, are there things that are much more important than others? In certain people, how do you, as a gastroenterologist who really specializes in nutrition, how do you actually tackle this anti-reflux lifestyle piece?
Sure. I think it's a really common question that we get asked by patients. And I also get asked at cocktail parties because of what I do. And I think that, it's really all about the personalization of the lifestyle modifications. And Alex really spoke about that very nicely. There's a lot of different dietary modifications and lifestyle modifications that can help reflux symptoms, but we don't know what will help your reflux symptoms until you actually engage with the different lifestyle changes. And, many times we do recommend doing things one or two at a time because then you can really isolate what actually is helping I can't tell you how many patients have come into me and worked with Alex as well, since we always work very closely with these patients that are on a very restrictive diet. They have this list of 20 things that they think they can't eat anymore because they were told they cause reflux symptoms. And the reality is they haven't really figured out if they cause reflux symptoms in them. And
Mm.
so our goal is often to reintroduce foods and see what is causing the symptom burden. In terms, some of these, recommendations, things like reducing smoking or alcohol, not eating super late at night. I think some of these things are healthy lifestyle choices and we would recommend them. But when we're talking about specific food elimination diets, this is really where there's a lot of opportunity to personalize.
Understood. So I think between working with someone like Alexandra and yourself, a lot of the success is really looking into an individual person's lifestyle, what they do. So it's really not one size fits all in terms of this. And I guess, Alexandra, you work very closely with individuals to sort of really tease out what may be their problem, because it could be that what might really work for one person might not work for another person.
Correct. And I also just wanted to highlight, there on that slide there, it says if overweight, weight loss. And that is something that, people don't always want to think about. But a modest weight loss, even a small amount, can reduce that abdominal pressure gradient and make a big difference with reflux if the patient is overweight.
Yeah, yeah. I think that some of the diets, obviously, maybe even some of the diets that are, anti-reflux actually can help people lose weight. They probably go hand in hand, some of those things as well. So these are all important things, trying to find your triggers, and whatnot. There's a lot of questions that are coming in, which we're going to get to as we go down this. But, you know, the mechanism. So we looked at the anatomy. We understood that these organs, the lung is near the esophagus, that there's a valve at the top of the esophagus, there's a valve at the bottom of the esophagus, the stomach getting distended with a big meal could play a big role in reflux disease. But, Dr. Katz, can you go back to some of sort of the mechanisms behind what actually is happening here? There's several things on this slide that I'd love you to just, briefly touch on so that we understand why an individual would be at risk for getting reflux disease.
Uh, I would be more than happy to. The top of the slide, the first bullet talks about an impaired junction. We've outlined what that is. Dr. Schnall showed you the picture as I try to talk you through it. The lower esophageal sphincter muscle, if you would, is a high pressure zone. The crural diaphragm is a breathing muscle that everyone is familiar with. We don't think about it, but that's the way we breathe. And together they created a zone of pressure that prevents reflux. We don't know exactly what impairs that. Perhaps it is overeating. Perhaps it is a genetic issue. Perhaps it's related to weight and what that does to inflammatory mediators that we don't completely understand. But when that does not function well, open when it's not supposed to by whatever mechanism, then a reflux episode occurs. Ultimately, it is refluxed to the esophagus. The esophagus has a reflex contraction that attempts to clear it. And the final step in neutralizing a reflux episode relates to the bicarbonate in saliva. So if you have a dry mouth because you have a decreased production of saliva, or you have a disease like Sjogren's syndrome that prevents you from making saliva, that might impair your clearance. Now, at the other end, where the stomach needs to do its job by digesting food and moving that digested material through the stomach into the small intestine, if that is delayed, that can increase the risk for reflux by leaving what you've eaten and gastric contents in the stomach for an extended period, and create some increase in distension. And those can contribute to reflux and symptoms as well.
Okay.
They're less common than the impaired junction, but they're nevertheless things we think about.
Well, one thing that I know many people have heard about is a hiatal hernia. So, where does this hiatal hernia play a role in reflux disease?
So what a hiatal hernia is, or what it means, is that part of the stomach slides up into the chest.
Mm.
When that happens, it usually is called a sliding hernia for a reason, because it's not always in the chest. That moves that junction up into the thorax or the chest, where the pressures are lower and slightly different than the abdomen. And the gradient between the belly and the chest changes, so the hernia allows for permission, if you would, to reflux. The anatomy itself, or the presence of a hernia, in most of us is additive or permissive for reflux and does not require being fixed, does not twist or strangulate, and as such is not dangerous.
Okay, so are symptoms from, and one of the questions that, came in from the audience was, do symptoms from a hiatal hernia need to be addressed differently from gastroesophageal reflux disease?
In general, the answer to that is no.
Mm-hmm.
There are times when the hernias are big, or there are other things that go along with it, but in general, the answer is no.
And do most people who have reflux disease also have a hiatal hernia?
At some point in time, almost everyone with reflux will have some form of a hernia. Because it moves and can slide, you don't always see it and you don't feel it.
Okay. Okay, understood. Okay, so let's get back to our case because we've been speaking about a lot of different things, that are going on. We want to find out what is going on with her. And so, in spite, she took a lot of this, suggestions that were given, about some of her diet and lifestyle. So, in spite of changing her diet by eliminating carbonated beverages, limiting herself to 1 cup of coffee a day, and not eating close to bedtime, she continues to have reflux. And now she starts to experience some pain with swallowing and maybe a little bit of difficulty, maybe even swallowing. But before we go into what happens to her next, I would love, Alexandra, to just talk about eliminating carbonated beverages, sticking to 1 cup of coffee a day. I mean, can people with reflux disease drink coffee? Because like we all talk about coffee, it's the first thing that people ask, do you drink coffee? So, what is it about coffee that causes reflux disease?
Well, caffeine, it's not just coffee, it would be caffeine in general, including black tea or what. It can relax the lower esophageal sphincter. Um, Coffee itself can also be a little bit acidic. So for kind of two reasons, coffee is singled out. I never tell patients that they have to fully eliminate it. I always want to start with kind of reducing it if they're having 3 or 4 cups of coffee a day. I really hate taking somebody's coffee away completely. So I think that 1 cup a day would have been my recommendation for this woman.
Okay. And, a lot of people drink a lot of coffee, but there's also difference in types of coffee. So, it's hard. Our center is in New York City. I don't know, there are people from around the country that are on the webinar today, but it's very hard to walk from block to block without seeing a coffee shop. And so, is there a difference between, let's say, a regular cup of coffee and espresso and those different types of coffee drinks? Just from the coffee standpoint, do you change your talking points with people about specifically coffee?
Not a ton that I'm aware of. I mean, I often recommend adding more milk, like not being so black, the
Mhm.
coffee. And then, there are some lower acid coffees you can get at the store, not necessarily at a coffee shop, or cold brew can sometimes be less acidic. So we can try some of those things and see if they make a difference in how the patient feels.
Okay. So it's really still watching, really watching, watching, watching. And then, Dr. Newberry, what about carbonated beverages? Is there something about sodas and carbonated beverages, which is another big drink that, people partake in? Is there something about those that particularly lead to reflux disease?
So it depends on the carbonated beverage. So for just bubbles in general, I mean, you're introducing excess air into the digestive tract, which can, in theory, change the pressure gradient. I think that the literature doesn't necessarily support the carbonated beverages are consistently associated with heartburn and reflux symptoms. And so that's why it is a personal journey, as Alex and I keep highlighting that, if you cut it out for a week or two and you feel better, carbonation may be contributing to your reflux, but definitely not you need to cut it out across the board. Additionally, a lot of carbonated beverages do have sweeteners and additives and caffeine and other triggers of reflux disease. So it's really looking at your food labels and understanding what you're drinking. Certain types of processed sugar intake actually has been correlated with increased reflux symptoms. The thought behind that is that these sugars get fermented and they may cause relaxation of that sphincter at the bottom of the esophagus. They also can lead to excess weight gain, which we discussed as a contributor to reflux symptoms. So this is why it's just so important to understand what the ingredients of the drinks that you're drinking are.
Okay, so, one of the questions that had come across is, you know, is there always a list? Is there always a list that you give people? And I guess just listening to what you're saying is that, yeah, there may be a list, but it really always keeps on going back to the individual patient and what actually causes potentially their reflux. And some of it is trial and error, for individual patients as well. So now the patient starts to experience some pain and maybe difficulty with swallowing. So, Dr. Katz, what does that make you think now? Is that something of concern to you in someone that has reflux disease?
Someone who has difficulty swallowing, delay in transport of food. Dr. Newberry alluded to that as a warning sign at the earlier in the webinar, and that would be something that would concern me, and make sure that I would do some testing to work that up. Painful swallowing is a little bit more complex, but again, is a warning sign that should require an intervention with a test that I believe we're going to talk about shortly.
Okay. So, so she's recommended to undergo an upper endoscopy. And, the purpose of that is, I think, what you were alluding to, that we're a little concerned that maybe this is not just, basic reflux that has not caused any maybe damage in the esophagus that's now giving this sort of escalation, in her symptoms. So when we start to talk about an upper endoscopy, that is a sort of a very specific test. And, there are these two quotes that are put out here. All that glitters is not gold, and all that burns is not gastroesophageal reflux disease. And so, Dr. Katz, could you just comment on this in terms of when someone presents with reflux symptoms, are you able to make the diagnosis just based upon those symptoms, or do you often need to go on to definitively say if someone has reflux disease?
Do I have to exhibit any knowledge of Shakespeare to answer
No.
this question?
No.
Um, it's actually a beautiful statement. Heartburn is not specific. Most heartburn is GERD, but any form of distension of the esophagus, any form of delayed movement or even spasm can feel like burning.
Okay.
It's a very strange organ that way, but there are a lot of mimickers of GERD. So no, it's not specific.
Okay. So that would lead us then to, how does a gastroenterologist actually diagnose GERD? And, I would love for you, there's a little video here afterwards that I'm going to show. But Dr. Katz, before we show the video, could you just talk about the ways that if someone is presenting with some of the symptoms that our patient presented with, what would you be doing to definitively say that that person has gastroesophageal reflux disease as the reason behind their symptoms?
So there are basically two tests. There are a lot of tests, but the two most definitive tests are on this slide. One is to do what we call an endoscopy, examine the esophagus with a scope that has the ability to actually see the lining. And if that doesn't give you a definitive diagnosis, a test that monitors a patient over a period of time. somewhere between 1 and 4 days, such that you can actually determine how much acid reflux occurs. And there is a normal amount that we all get. And if you have extra, more than that, then that is a diagnosis of GERD. The ambulatory testing, as you'll show in a moment, allows you to also relate symptoms to a reflux episode.
Okay, so I'm going to just briefly show, this video. And
clear indication.
hold on, let me see here. I think there's some sound. I'll try to take that off. Okay, so could you just describe what you're seeing there, Dr. Katz?
So what you see right in the lower and moving right past you is an erosion. That's a break in the lining of what is normally a whitish appearance that almost looks a little bit like the skin. And when there's inflammation and reflux esophagitis, you see those erosions, and that is diagnostic of excess acid exposure and is a definitive diagnosis of gastroesophageal reflux disease.
So what exactly caused that erosion? What happened inside of that person's esophagus that led to that?
Sufficiently excess acid exposure that allowed for a breakdown in the mucosal defense that allowed acid to enter through the lining, reach the nerve endings and give symptoms, and stay there long enough to produce inflammatory mediators that caused injury.
Okay, so that's a very complicated sentence that you just said, but basically what I'm hearing is that the acid is going.
I count on you to make it simple.
Yes. Well, the acid went up into this esophagus. The esophagus is able to tolerate a little bit of acid. There's a lot of different mechanisms to protect the esophagus. When we spoke about some of those, the saliva has these, sort of nourishing components in it that protects the esophagus. The esophagus has like a little bit of mucus lining in it to protect it. We swallow, we keep on swallowing to try to keep but if too much acid keeps on going up into that esophagus, it's basically going to start to break down the lining of the esophagus, and this is basically a wound. Basically, this is a wound. If you were to pour acid, let's say on your skin, that is basically what's happening in the esophagus. And then because of that, it's starting to hit the nerve endings and you're starting to get pain.
That is correct.
Okay, so now if we move on to now, sometimes we might see those findings, and some people we might not see those findings. And then you described that there are some other tests to actually do to be able to determine whether or not there is additional acid. So, Carolyn, can you just describe for us a little bit about the testing that you might go for? Let's say the person doesn't have those erosions that we spoke about on endoscopy. What would you do then to try to nail the diagnosis?
It's a great question. So, if the endoscopy looks normal, so the esophageal mucosa looks healthy, there's no evidence of breakdown like we just saw in that video, there is more sophisticated testing that we can offer to make the diagnosis. And here on the screen, you can see an example of one of these tests. This is a catheter-based test. So it is a test where we put a tiny tube into the nose. We leave it there for 24 hours, and this tube actually goes into the digestive tract and is able to measure acid levels. And so it can determine whether acid levels are elevated. So it's a more accurate way of diagnosing reflux because many people with reflux disease don't have inflammation in their esophagus. So things look normal, but when we do a more formal test like this, we can determine that they're not normal.
Okay, so this tube actually goes down their nose and sits in that esophagus. How long does it sit in that esophagus for? A full day?
So it's a 24-hour period.
A full day, that tube sits in the nose. Okay.
That's
And
true.
basically what you're trying to see is whether or not there's acid that's coming up when they're actually feeling the symptoms. And that kind of correlation between the acid coming up, and you can actually see it on this test, that acid has come up into the esophagus. Okay, I'm sure that must be, as we say, a fun test, but it gives a lot of information. Now, I'm sure there are a lot of people who don't love this test. And so, Dr. Katz, what are we looking at here? What test is this?
Thank you for giving me the easy one. This is a wireless capsule-based reflux or pH monitor. It's placed on the esophageal wall very safely during an endoscopy. It connects by Bluetooth to a recording device that the patient carries within 3 feet of them for 4 days. They keep a diary, and then that capsule there falls off by itself, comes out in the stool, is not brought back, and the recorder then allows us to see how much reflux happens over that 4-day period.
So why would someone have this test, this wireless test done versus the catheter test in the nose that Dr. Newberry was talking about?
If you're asking me, it's more patient friendly because there's no catheter, no tube. It rarely creates any symptoms, so it is essentially painless. It allows for a normal diet, normal exercise, and it can be placed during the time of an endoscopy. So one visit can allow us to make a very clean, objective diagnosis of reflux with 2 tests.
So, one of the questions that came in had to do with how would you determine between angina and reflux disease? Do any of these tests help us? Because there are individuals that can present with chest pain, right? That might be their reflux symptom. So, what is important? What do you initially do if someone comes in with chest pain and we're trying to decide if it's reflux disease? Do you treat them any differently than someone that's presenting with, let's say, heartburn or regurgitation?
Uh, my standard approach is that the heart is more dangerous. Anything bad, anything related to coronary artery disease is much more dangerous than reflux. Reflux is annoying. It feels like you're dying, but you're not. So I almost always ask the patient if they've had cardiac disease ruled out. Sometimes it's a little tricky in a 22-year-old, but in general, I want to be really comfortable that uh, it's not the heart because the symptoms can be absolutely identical.
Okay. So they could be very similar, but if there's any concern about this being cardiac, they're going to be seen initially by a cardiologist to just exclude heart disease, and then you're going to move on to these types of tests. So, Dr.
Yes.
Newberry, so this pill that we place, it just falls off on its own. It doesn't get removed.
So that is correct. The way these catheters are designed is that little probe that you see in the picture there, which is magnified, it's actually very tiny, gets suctioned to the wall of the esophagus, as Dr. Katz explained to the group, and then over a period of time, usually about a week or so, it's going to fall off on its own and it's going to pass through the digestive tract. So as we always tell patients, we don't need that part back. We just want that wireless device that's monitoring the information during the test itself.
Okay,
Yeah.
great.
And
Okay.
and I would say, Dr. Schnoiders, really quickly, the catheter, which was the only thing we had for a very long time, um, while it appears to be very uncomfortable, is actually the size of a piece of spaghetti.
Hmm.
And it's done as an outpatient. You can eat and drink, you can exercise, understanding most people don't want to go outside with a tube in their nose. But the whole idea is to eat and drink normally for that 24-hour period and produces very, very important information for us if we choose to use that test.
Okay. Great. So the patient had pretty severe erosion seen on their endoscopy, grade C esophagitis, was recommended to go on to a proton pump inhibitor medication. Okay. So these medications play a big role, and I'm sure it's probably the rare person, especially those that have reflux disease, that have not heard about proton pump inhibitors. So, Dr. Katz, could you just very briefly discuss what is a proton pump inhibitor and how does it work in treating reflux disease?
So this is a medication that is taken by mouth. It is uh, taken daily because the way it works, it requires multiple dosing to be at its maximum effect. What it does is to block the final step of acid production in the cell that is in the stomach that makes acid. By doing that, it prevents through an enzyme, it prevents the production of acid, to keep
Okay.
simple.
Okay, perfect. And so it's a very common medication. I know we hear a lot about those medications, and a lot of patients are on these medications. And this graph sort of is looking at the whole spectrum of some of the different medications that individuals might actually be on for reflux disease. Is there, I would love for you to just discuss, there's one class of medications here that our group might not be familiar with, patients might not be familiar with, and that is the potassium competitive acid blockers, also known as PCABs. You just gave us, a nice description of how proton pump inhibitors work. I'm sure individuals are going to start to see a lot of advertisement on these PCABs. Do they act differently than proton pump inhibitors, or are they just super proton pump inhibitors?
Um, at a very basic level, they are different. They block acid in a subtly different way, but still block that same proton pump, if you would. The same enzyme that the proton pump inhibitors block are blocked by these PCABs. They do it in such a way that the acid control is more powerful. The speed of onset is different. Uh, they only need to be taken once a day and can be given a little more diversely, so to speak, than proton pump inhibitors, which really need to be taken before a meal. The simple answer is that they are different. They are not super PPIs or super proton pump inhibitors, and will add a lot to our ability to treat people, particularly with difficult symptoms.
Hmm. So, I'm going to go back just because we've received so many questions from the audience, and one, Alexandra, maybe you can actually touch upon, and there might not be a good answer to this, but we spoke a little bit about tobacco cessation. Does that include cigars, which people say are not inhaled? And I don't even know that I specifically know the answer to this, but I'm just wondering people's opinion on this. There are people who walk around with a cigar in their mouth. Does that do we have any idea if that causes reflux disease?
I'm not sure.
They
No,
actually don't.
they don't.
No, no, cigar smoke, well, it doesn't do the same as the nicotine that is in the regular cigarette, and the cigar effect on sphincter pressure and acid production is different.
Okay. I just put it out there because it's certainly it's not I don't see that many people that actually walk around with cigars. And I just wanted us to sort of get that out there. Now, we're talking a lot
I mean,
about medication.
there are a lot of reasons not to smoke cigars, by the
Sure.
way, but they're not as bad for reflux as regular
Okay.
smoking. Okay.
So, what about we see all these medications here. What about silent reflux? There's a lot of conversation about silent reflux. Dr. Newberry, can you just explain, what is silent reflux?
Sure. I mean, I think, when we think about reflux classically, we think about people that have classic associated symptoms. We talked about the heartburn and the regurgitation. There are people, though, that have reflux stomach contents that's acidic that can cause damage to the esophagus, can cause damage to the lungs, and they may not have classic symptoms. And so it's more of a silent disease. I mean, just like we talk about, blood pressure being like a silent killer because people don't feel symptoms associated with it. There are people that don't have classic symptoms.
Okay. So not classic symptoms, or, maybe they actually have side effects from reflux and they don't even feel anything, right? They're not feeling anything at all. And then you can potentially go in and even they have signs or, signs of actually having reflux disease. So this is, Dr. Katz, I know you were the lead author on the recent American College of Gastroenterology guidelines on gastroesophageal reflux disease. And this is a very large paragraph. And I don't want you to read this paragraph, but there are many questions that came in the chat that have to do with proton pump inhibitors and whether or not these are safe medications. So can you just give us the understanding as to whether or not these are safe medications, and if there are any things that we have to worry about, what are they with proton pump inhibitors?
Um, they're incredibly safe medications. They've been available in the United States since 1989. Some of us have been treating patients for that long and do have patients who've taken them for a long time. The FDA has been very careful to look very, 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 very acutely and very, very in detail at many of these potential adverse events. The cause and effect has been very difficult to prove. And in fact, there's no laboratory evidence that there is a direct cause and effect on any of these. So it's a balance between risk and benefit. If you're going on a trip to Mexico and you're on a PPI, you should talk to your doctor about whether you should hold it or just be prepared that there might be an increased risk of infection. There are some very, very rare conditions in which one might worry about these interactions, but they are at best associations and not easy to prove cause.
Okay, so they work really well. And basically, there's been a lot of hype about side effects, but in general, these are safe medications so long as you're treating the right disease. I think the key thing is really having the patient on the lowest effective dose to treat them. So a lot of patients get put on these medications. They never go off the medicines. There's not really a concept or a thought about actually taking them maybe down on the medicines or off of the medicines. I think that's probably the good thing to do, right? Safe to go on them, but go on the dose that you need rather than just staying on a high dose or being put on double high dose or things of that nature, and making sure we actually know what we're treating in that patient.
That
So
is correct.
yeah,
Mhm.
so going back to our case, she reports resolution of her symptoms, including pain and swallowing, after being on the proton pump inhibitor, for 2 weeks. And what I would say for that is, and this is like another little nice quote for us, but in the our last minute together, um, there are a lot of other alternative treatments. How do you know when you need to go beyond medication? And just not that I want you to go through all the potential surgical considerations, because we're going to have additional webinars on surgery and reflux disease. But Dr. Katz, if you could give us 30 seconds on who you might consider actually referring to surgery with reflux disease.
Somebody with very severe erosive disease that requires a whole lot of medication, somebody who does not want to take medication, somebody with a very, very, very large hiatal hernia, and it would have to be taken up more than half of the chest. In general, someone who's responded to medicine and doesn't want to take it, or someone who, for whatever reason, is refractory, particularly if they regurgitate, those are best candidates for surgery.
Okay, wonderful. Well, we went through an enormous amount of information this evening. This webinar is being brought to you from Weill Cornell Medicine, specifically from a program called DIGEST, which stands for Dedicated Integrated Gastroesophageal Treatment Program. This is just some of the pictures of the many different team members that are part of the DIGEST program. It takes both gastroenterologists, surgeons, ear, nose, and throat doctors, pulmonologists, dietitians to actually manage these patients. And I hope this evening we had an opportunity to touch on a lot of the topics with reference to reflux disease and the way that we manage those conditions. We've answered a lot of the questions this evening. And if you have additional questions or concerns, please come see one of the many wonderful physicians at Weill Cornell Medicine. I'd like to thank you this evening on behalf of myself, Dr. Felicia Sussman, and my other colleagues who joined me this evening on this talk. I hope everyone has a nice evening, and we look forward to seeing you at additional webinars every month concerning really interesting topics related to diseases of the esophagus and foregut. Thank you so much. Have a good evening.